Bismillahirrahmanirrahim. I am Dr. Zia. I welcome all of you from the platform of mmkhub.com. I appreciate your decision of selecting MMK for learning purpose. We are discussing stomach. In the first lecture, we discussed the anatomy of the stomach. In the second lecture, we discussed the physiology portion of the stomach. We all know that when physiology goes wrong, it becomes the pathology. So today, as in third lecture, we will discuss the stomach pathology. First of all, gastritis. What is gastritis? It is the inflammation associated with mucosal injury and needs biopsy to get confirmed. It can be secondary to the infectious agents such as the Helicobacter pylori and autoimmune and hypersensitivity reactions. There are various factors which affect the mucosal lining. These can be protective factors and the hostile factors. In normal physiological condition, there is a fine balance between the protective factors and the hostile factors. Hostile factors include the Helicobacter pylori infection, gastric acid, pepsin, non-steroidal anti-inflammatory drugs, and the protective factors include bicarbonate, prostaglandins, mucus production, and blood flow to the mucosa. If this balance disturbed, for example, if the weightage of the hostile factors increases, it causes the damage of the mucosal surface of the stomach and lead to the peptic ulcer formation. In this diagram, you can appreciate different defense mechanisms and their effect on prevention of the damage by the damaging forces. In normal circumstances, damaging forces like the gastric acidity and peptide enzyme effect is balanced by the defensive forces. For example, the surface mucus secretion, bicarbonate secretion into the mucus, mucosal blood flow, apical surface membrane transport, epithelial regenerative capacity, and elaboration of the prostaglandin. All these defensive forces counteract the damaging forces and keep the mucosal surface of the stomach in a normal state. But when there is injury, for example, Helicobacter pylori infection, non-steroidal anti-inflammatory drugs excessive use, aspirin use, cigarette smoking, alcohol intake, gastric hyperacidity, duodenal gastric reflux, and if these factors are there, they can damage the mucosal surface and lead to the peptic ulcer formation if the defensive forces are inadequate. For example, in cases of ischemia, shock, which lead to the decreased blood supply of the mucosal surface, delayed gastric emptying, and host factors. If these factors are there, it will lead to the impaired defensive mechanism and ultimately the mucosal surface of the stomach get damaged and lead to the gastric ulcer formation. Gastritis can be divided into acute and chronic. Acute gastritis is a short-term inflammation, while the chronic gastritis is present in long-standing cases. In acute gastritis, mucosal inflammatory process with neutrophilic infiltrate is present, while in chronic gastritis there are especially lymphocytic and macrophages infiltration. In acute gastritis, there may be hemorrhage into the mucosa or sloughing of the mucosa, while in chronic gastritis, it can lead to the mucosal atrophy, intestinal metaplasia, and dysplasia. Gastritis. Etiology of the gastritis. Acute gastritis caused by the drugs, toxins, alcohol ingestion, ischemia, or the infections due to the Helicobacter pylori, while the chronic gastritis can be due to the autoimmune process due to the autoantibody formation leading to the pernicious anemia, while it can be due to the chemicals ingestion, for example, the non-steroidal anti-inflammatory drugs, bile reflux, or the alcohol intake, and the bacterial infection with the Helicobacter pylori. Now we will discuss in detail about the acute and chronic gastritis. Acute gastritis, the etiological factors include excessive alcohol consumption, heavy use of non-steroidal anti-inflammatory drugs, especially aspirin, heavy smoking, severe stress, for example trauma and burns or post-surgery cases, ischemia, which lead to the decrease in the blood supply of the mucosal surface, systemic infection, and most often it can be idiopathic, means there is no known cause. Smoking. Smoking promotes gastritis and ulcer occurrence. It increases the likelihood of the ulcer complication. What is the mechanism behind the ulcer formation in cases of smoking? It includes that smoking stimulates the gastric acid secretion, it stimulates the bile salt reflux, it causes the alteration in the mucosal blood flow, it decreases the mucus secretion, it reduces the prostaglandin synthesis, which acts as a protective mechanism, and it decreases the pancreatic bicarbonate secretion. Effects of diet and stress. Unhealthy diet can lead to the dyspepsia, which may cause the pain, but it is not believed to cause the ulcer formation. In physiological stress, there is decreased mucosal blood flow, leading to the tissue hypoxia, mucosal lining degradation. For example, in ICU patient or patient with sepsis, burn or trauma. It is associated with multiple erosions and significant bleeding. Acute gastritis. Clinical features of acute gastritis include signs and symptoms that depends on the severity of the condition. It may be asymptomatic or the patient may present with the epigastric pain, nausea and vomiting, and in severe condition there can be hemorrhage, massive hematemesis, melena, or fatal blood loss. One of the major causes of massive hematemesis, particularly in alcoholics, is acute gastritis. Approximately 25% of patients taking aspirin for rheumatoid arthritis will develop acute gastritis, and some can bleed. Chronic gastritis is further divided into type A and type B. Type A is autoimmune gastritis, while the type B is enteral gastritis. In the next slides, we will discuss these types in brief detail. Type A, which is the autoimmune gastritis. The etiology includes the autoimmune process in which the antibodies are formed against the parietal cells. Gastrin receptors, intrinsic factor, and hydrogen potassium ATPase. Less than 10% of cases of chronic gastritis are autoimmune, and possible autosomal dominant inheritance is suggested. Type B or enteral gastritis. 90% of patients with enteral chronic gastritis are associated with the Helicobacter pylori infection. Helicobacter pylori is a motile gram-negative curvilinear rod that elaborate urease and toxins and have adhesins to bind to the gastric epithelium. There are two patterns of infection. One is the diffuse involvement of the body and the antrum, leading to the pangastritis, which is associated with diminishing acid output, and the second is infection confined to the antrum, leading to the antral gastritis, which is associated with increased gastric output. Helicobacter pylori is adaptive to live in the association with surface epithelium beneath the mucous barrier. It causes the cell damage and inflammatory cell infiltration. In most countries, Majority of the adults are affected. This is the table comparing the features of the Helicobacter pylori associated antral gastritis and autoimmune gastritis. H. pylori associated gastritis is mainly located in the antral region of the stomach, while the autoimmune gastritis mostly involves the body of the stomach. Inflammatory infiltrate include neutrophils, subepithelial plasma cells in H. pylori associated gastritis, while in autoimmune these are the lymphocytes and macrophages. Acid production is increased to slightly decreased in H. pylori associated gastritis, while it is decreased in autoimmune gastritis. While the gastrin secretion is increased in autoimmune or normal to decrease in H. pylori associated. Similarly, the serology will give antibodies to H. pylori titers in cases of H. pylori associated gastritis, while in autoimmune gastritis there are the antibodies to H. parietal cells. Hydrogen potassium ATPase and intrinsic factor will be raised. Sequelae of the H. pylori associated gastritis include peptide ulcer formation, adenocarcinoma, and maltoma, while the sequelae of the autoimmune gastritis include the atrophy of the gastric epithelium, pernicious anemia due to intrinsic factor deficiency, adenocarcinoma formation, and carcinoid tumors. The association of H. pylori associated gastritis is with the low socioeconomic status of the patient, poverty, and the residence in the rural areas, while the autoimmune diseases are associated with the autoimmune gastritis, for example, thyroiditis, diabetes mellitus, and Graves' disease of the thyroid. Chemical gastritis is a form of chronic gastritis. It is commonly seen with the bile reflux condition because bile is toxic to the gastric cell. There is prominent hyperplastic response, and with the passage of time, if the insult is present, it can lead to the intestinal metaplasia. Clinical feature of chronic gastritis: usually only a few symptoms are present, for example, the nausea, vomiting, and upper abdominal discomfort. Most infected persons have gastritis but are asymptomatic. Hypochlorhydria may be present, but there is no achlorhydria, and the pernicious anemia will be there, but the parietal cells never completely destroyed. Gastrin can be normal to slightly elevated, and the treatment of choice in cases of chronic gastritis is antibiotic therapy. Now the other pathological conditions of the stomach. First of all is the Menetrier's disease. In Menetrier's disease, there is the epithelial hyperplasia involving the surface and the foveolar mucosal cells. That is the foveolar hyperplasia. The augmented cell can be normal or atrophic in this condition. Next is the Zollinger-Ellison syndrome. In Zollinger-Ellison syndrome, there is increased number of parietal cells with no change in the surface and foveolar mucosal cells. Then is the hyperplastic gastropathies. This is the mixed type in which both the mucosal and the ausented glandular cells shows hyperplasia. It may be seen in as lymphocytic and H. pylori associated gastritis. Helicobacter pylori peptide ulcer disease. It is a common infection which involves 10% of the men and 4% of the women during their lifetime. Helicobacter pylori infection is positive in 70 to 100% of the peptide ulcer disease patient. Most common site involved is the first part of the duodenum, then the antrum of the stomach, and then the gastroesophageal junction. H. pylori related disorders include, in 90% of the cases, chronic gastritis, in 95 to 100% of the cases, peptic ulcer disease, 70% of the cases of gastric carcinoma has H. pylori infection. Similarly, gastric lymphomas, reflux esophagitis, and non-ulcer dyspepsia can also be related with the H. pylori disorders. What is the pathogenesis of the H. pylori related peptic ulcer disease? H. pylori is a gram-negative spirochete. It does not invade the cells, but it colonizes the acidic gastric mucosa only. The effect of the H. pylori is activation of the proteases which break down the mucus, expose the epithelium for digestion and urea formation. Similarly, activation of the urease leads to the breakdown of the urea to ammonia. This ammonia neutralizes the acid of the stomach. There is the reflex and then the hyperacidity of the stomach, which damages the mucosal epithelium. Chronic infection leads to the gastric metaplasia and ulceration of the gastric mucosa. The complications of the H. pylori infection are bleeding, perforation, stenosis, and carcinoma formation. This is the diagram which is showing the pathogenesis of the H. pylori gastritis. In the left upper diagram, you can see that the Helicobacter pylori penetrates the mucosal layer of the stomach and affects the epithelial cell. In the second diagram on the right upper side, you can notice that it brings about the changes in the by the activation of the urease and proteases and lead to the damage of the gastric epithelial cell. And in the right lower diagram, you can notice the mucosal damage by the bacterial mucinase, and there is the inflammation of the gastric epithelial cells by the gastric acid, proteases, and effector molecule. And ultimately, will be the mucosal cell death by the cytokines and ammonia, and this ultimately leads to the gastric ulcer formation. Classification of the gastric ulcer. Gastric ulcer can be classified into 4 types: type 1, type 2, type 3, and type 4. This classification is according to their location in the stomach. Type 1 is present in the gastric body, and low gastric acid production is associated with these ulcers. Type 2 is present in the antrum of the stomach, and gastric acid secretion can vary from low to normal, while the type 3 is present within 3 cm of the pylorus of the stomach and are commonly accompanied by the duodenal ulcer. There is normal or high gastric acid production in case of the type 3 gastric ulcer, while the type 4 gastric ulcer are present in the caudate region of the stomach and associated with the low gastric acid production. What are the different investigations for the H. pylori infection? These can be invasive investigation or non-invasive investigation. Invasive investigation include the endoscopy and biopsy. Similarly, rapid urease test, histology of the stomach as a result of the specimen taken by the biopsy, and the culture of the epithelium of the stomach. And non-invasive tests include the serological test, urea breath test, and stool antigen test for the H. pylori. Peptic ulcer morphology. Peptic ulcers are 4 times more common in the duodenum than the stomach. In more than 80% of cases, there is single ulcer, which is round, small, and clean. Punched out ulcers are usually less than 2 cm in size. There are usually radiating folds around of the mucosa around the ulcer. Microscopically, as shown in the lower diagram, there is the superficial necrotic layer, which is designated by the letter A in the diagram, inflammatory cell zone, and then the granulation tissue zone, which is shown by the letter B in the diagram, and then the collagenous scar zone, which is shown by the letter C. Complications of the peptic ulcer disease. Peptic ulcer disease can lead to chronic bleeding, which can result in the anemia, and the type of anemia in this case will be the iron deficiency anemia due to the bleeding. There can be acute bleeding, which can lead to the shock if it is massive in nature. It can lead to the pyloric stenosis due to the fibrosis and stricture formation, which lead to the obstruction. There can be perforation, which can lead to the peritonitis and pancreatitis if the peptic ulcers are located anteriorly. And finally, there can be gastric carcinoma, which is common in cases of the peptic ulcer present in the stomach but not in the duodenal ulcers. Gastric carcinoma. Mostly gastric carcinoma or adenocarcinoma in about 90% of cases. Rare varieties are lymphoma 4% and carcinoid and stromal tumors. Adenocarcinoma can be intestinal and diffuse types. If it is limited to the mucosa, it is labeled as early gastric carcinoma, while if it has extended beyond the mucosa, then it is advanced stage gastric carcinoma. Gastric lymphoma is marked gastric lymphoma, which is of B cell origin, and it has association with H. pylori infection. Laurent classification classifies the gastric carcinoma into 4 types. First is the intestinal carcinoma, which is seen in the elderly patient, mainly males. Now it has decreasing incidence everywhere and associated with the blood-borne metastasis. Diffuse carcinoma is seen in the younger patients, mainly females. It has familial or hereditary associations and dissemination is to the peritoneum. Third type is the mixed variety, which has approximately equal quantities of intestinal and diffuse component, and fourth type is the indeterminate variety, which are the undifferentiated tumors. This slide is showing the comparison between the intestinal type and diffuse type of the gastric adenocarcinoma. Intestinal type is associated with H. pylori metaplasia, while the diffuse type is idiopathic and has familial association. Intestinal type is associated with the chronic gastritis and atrophy of the gastric mucosa, while in diffuse type there is no precursor lesion. HAL2 mutation is seen in the intestinal type, while the mutation in the E-cadherin gene is present in the diffuse type. Intestinal type is fungating, well differentiated, and early diagnosis is possible, while in diffuse type there is diffuse and infiltrating lesion which are poorly differentiated, so the diagnosis is mostly late. There is no signet gland formation, but gland formation is present in the intestinal type, while in diffuse type signet gland cells are present, but there is no gland formation. As a whole, intestinal type has a better prognosis, while the diffuse type has poor prognosis. As far as the geographical distribution is concerned, intestinal type is more prevalent in the Eastern Asia, Eastern Europe, and Central and Latin America. while the diffuse type is more prevalent in the North America, Northern Europe, Africa and Southeastern Asia. Site of the carcinoma in the intestinal type is the antrum and the pylorus, while the diffuse type is more prevalent in the proximal stomach and the cardiac region. Proportion of early gastric cancer is high in the intestinal type and low in the diffuse type. Now, the morphologically, the classification is called the Borman morphological classification, which divides the carcinoma of the stomach into four types. Type 1 is the polypoid, type 2 is the fungating mass, type 3 is ulcerative, and type 4 is the infiltrative type. As far as etiological factors of the gastric carcinoma is concerned, gastric carcinoma etiology is multifactorial. Different environmental, genetic and host factors are involved. For example, environmental factors include infection with the H. pylori, different diets containing the nitrites, for example, the smoked and salted foods, preserved foods, pickled vegetables and chili and peppers. It is more common in the low socioeconomic status and the cigarette smokers. Genetic factors include slightly increased risk with the patient of blood group A, family history of the gastric cancer, history of hereditary non-polyposis colon cancer syndrome, and history of the familial gastric carcinoma syndrome. While the host factor includes the presence of chronic gastritis, history of partial gastrectomy, presence of the gastric adenomas, and Barrett's esophagus. For screening purpose, we have option of barium meal, upper gastroesophageal endoscopy, and serum pepsinogen levels. And for the staging purpose, we have options of endoscopic ultrasound, which is much sensitive for the T staging of the tumor, and CT PET scan or CT scan alone for the N and M staging of the cancer. On the basis of grading, we divide gastric carcinoma into well differentiated, moderately differentiated, and poorly differentiated carcinoma. Differentiation depends upon how closely the tumor cell resembles the original cell type. For example, in well differentiated carcinoma, the tumor cells are more likely resembling to the original gastric cells, gastric epithelial cells, while in the poorly differentiated carcinomas of the stomach, the tumor cells are least likely resembling with the gastric epithelial cells. On the basis of differentiation, if the tumor is well and moderately differentiated, we will label this tumor as low-grade tumor, while if the tumor is poorly differentiated, we will label it as the high-grade tumor. Means, as the grade becomes higher, the differentiation of the tumor becomes poorer, and hence the prognosis of the tumor becomes poor. Means, the poorly differentiated carcinomas or the carcinomas with high grade have a poor prognosis as compared to the low grade or well and moderately differentiated carcinomas. Now, the tumor spread and staging of the gastric carcinoma. Intestinal type of gastric carcinoma spread hematogenously, means via the blood-borne method, and the main dissemination is to the liver, while the diffuse type mostly spread via the serosal involvement and the lymphovascular invasion and lymph node metastasis. The involvement of the duodenum is via the submucosal and subserosal routes. Carcinoma penetrates the serosa and leads to the peritoneal implantations. And if this transperitoneal and hematogenous involvement occurs in the ovaries, it is termed as Cruttenberg tumor. For staging purpose, nodal dissection is done for detection and removal of the metastatic disease and to do the appropriate staging. Accuracy of the pathological staging is proportional to the number of regional lymph nodes examined and their anatomical location in relation to the neoplasm. That's all for the gastric carcinoma topic. Now, other pathological condition. First of all is the Peutz-Jeghers syndrome. It is also known as the hereditary intestinal polyposis syndrome. It is an autosomal dominant genetic disease characterized by the development of the hematomatous polyp in the gastrointestinal tract and hyperpigmented molecules on the lips and oral mucosa. The cause is mutation of the serine threonine kinase gene STK11 LKB1, and it is commonly present in the childhood and the adolescence. Size of the polyps in this syndrome is approximately 1 to 3 cm, while the surface of the polyp is coarsely lobulated with short, broad stalk. Histologically, the most useful diagnostic feature is the presence of a core of finely arborizing branches of smooth muscle from the muscularis mucosae. The core is covered with abundant mucosa identical with that of the stomach but often disorganized. Predominantly, it consists of surface and foveolar epithelium, although occasionally antral glands and small cysts may be found. Inflammation is usually not prominent and there is low risk of developing carcinoma. Next type of polyp is the juvenile polyps, which is also called as retention polyp. Surface of the polyp is rounded and smooth, and the size is approximately 1 to 2 cm in diameter. Association is with the genetic mutation of SMAD4 on chromosome 18 and PTEN on chromosome 10. Histologically, it consists principally of the lamina propria, which contains irregularly shaped cysts lined by the normal gastric epithelium. Repeated episodes of torsion may produce the stromal hemorrhage, surface ulceration, and the secondary chronic inflammation. Juvenile polyps are small, but there is a definitive risk of colorectal cancer and gastric cancer in the patients with juvenile polyps. Third type of polyp is the hyperplastic polyp, which are also called as regenerative or hyperplasiogenous polyp. It is common in both children and adults, and if the adults are involved, it occurs in the fifth and sixth decade of their life. Occasionally, mostly it occurs at junction of the pyloric and corpus mucosa. Mostly these are multiple in number and the average size is 1 per 4 cm. Surface of the polyp is coarsely lobulated, and if the polyp is small, it is mostly sessile, while if the polyp is large, then it has a short, broad stalk. Regarding the presumed pathogenesis of the hyperplastic polyp, it is the exaggerated regenerative response to the mucosal damage. Adjacent non-polypoid mucosa shows the chronic atrophic gastritis. Hyperplastic polyp rarely undergo the malignant change, and if malignant change has to occur, the polyp size is usually greater than 2 centimeters. Histologically, the hyperplastic polyps are elongated, distorted and branched gastric foveolae, often abundant lamina propria which may be inflamed and edematous. Frequently, foveolar cells are hypertrophic with excess superficial cytoplasm with or without intestinal metaplasia. Nuclei are typically bland and resembles normal gastric pit, but in areas of heavy inflammation, regeneration can produce nuclear enlargement with prominent nucleoli. Fourth type is the funded gland polyp. It accounts for 50% of all gastric polyps, occurs as isolated sporadic lesions that are usually of little clinical significance. However, funded gland polyposis, that is the presence of polyps of 10 or more in number, has been described in two clinical situations. First is the following drug therapy for the gastric acid suppression, and second is in the conditions of familial adenomatous polyposis, where many hundreds of polyps are present. In familial adenomatous polyposis, the polyps are true neoplastic lesions showing mutation in the APC gene. 25 to 50% prevalence of dysplasia in the foveolar epithelium and may rarely give rise to the adenocarcinoma. In sporadic and drug therapy related polyps, there is no dysplasia, there is no mutation in the APC gene, but they may have mutation of the beta-catenin gene. Macroscopically, funded gland polyps are minute mucosal bumps 1 to 16 mm in diameter and occurs in the gastric body and the fundus. Microscopically, funded gland polyps are single or small groups of cystically dilated funded glands lined by the attenuated but otherwise normal layer of chief cells, Preiter's cells and mucous net cells. Inflammation is typically minimal or absent in funded gland polyps. Adenomas. Adenomas comprise 7 to 10% of all gastric polyps. Most of the adenomatous polyps are sessile and grow in tubulovillous or pure villous pattern. Pure pedunculated tubular lesions are rare. Usually, solitary lesions are less than 2 cm in size. Histologically, there are two types of adenomatous polyps. First is the adenomas showing the intestinal differentiation. For example, presence of goblet cell and or Paneth cells, which arises in the mucosa that shows the intestinal metaplasia. And second is the adenoma showing the gastric differentiation, that is the presence of columnar cells containing the neutral mucin, and arises in mucosa that is either normal or show minor inflammatory features. Adenomatous polyps larger than 2 cm and those with the intestinal differentiation have significant chance of becoming malignant. Overall, carcinoma may be present in up to 30% of the gastric adenomas. By definition, all gastric adenomas have epithelial dysplasia that is classified as low or high grade dysplasia. Both grades of dysplasia include enlargement, elongation and hyperchromasia of the epithelial cell nuclei. Second feature is epithelial clouding and third feature is pseudostratification. Next is the menetrier disease. It is a poorly defined entity which is diagnostic criteria for this disease include giant mucosal folds involving the corpus and possibly antrum of the stomach, Second feature is low acid production even after stimulation. Third is the mucosal protein loss. Histologic findings of corpus, foveolar hyperplasia and glandular atrophy. Histological features include elongation of the gastric foveolae on the surface of the folds and may have corkscrew appearance. Often cystically dilated with the mucus accumulation, and the cyst extends into the deeper mucosal rear and even occasionally the submucosa, with resultant corpus gland atrophy. Next is the gastric lymphomas. WHO definition of gastric lymphoma is: primary gastric lymphomas are defined as lymphomas originating from the stomach and contiguous lymph nodes. Lymphomas at this site is considered as primary if the main bulk of disease is located in stomach. Majority of the gastric lymphomas are high-grade B-cell lymphomas, some of which have developed through the progression from low-grade lymphomas of mucosa associated lymphoid tissue, which are then labeled as malt lymphoma. The low-grade lesions are exclusively B-cell malt lymphomas. 40% of non-Hodgkin lymphomas arise in the extranodal site, out of which GI tract is the most commonest. Gastric lymphomas constitute over 10% of all gastric malignancy, common in the patient of more than 50 years of age, while the sex ratio is equal in both male and female. Etiological factors include H. pylori infection and immunosuppression. Malt lymphomas. Malt lymphoma is low-grade lymphoma. It can transform to high-grade type, which is called the diffuse large B-cell lymphomas, which we will discuss in next slides. There are 5 cardinal histological features of malt lymphoma. 1. An infiltrate of small lymphocyte and small cleaved follicle center, centrocyte-like CCL cells. Second, lymphoid follicle. Third, neoplastic plasma cells. Fourth, lymphoepithelial lesions. And 5, Dutcher bodies, PAS, positive intranuclear inclusions. As far as pathogenesis of malt lymphoma is concerned, the normal gastric mucosa contains scattered lymphocyte and plasma cells, but is devoid of organized lymphoid tissue. First step in development of primary gastric lymphoma is acquisition of organized lymphoid tissue from which lymphoma can arise. In most cases, it is associated with H. pylori infection. H. pylori do not directly stimulate the malt lymphoma cell, but it causes the secretion of the interleukin-2 from the adjacent T cell and induce interleukin-2 receptors on tumor cells. Lymphocyte infiltrating the epithelium of the stomach is highly characteristic of malt lymphoma, but it can also be present in lymphocytic gastritis. Then, how to differentiate malt lymphoma from lymphocytic gastritis? In lymphocytic gastritis, the lymphocytes, which are the T cells rather than the B cells, are usually present as single cells within the epithelium, while in lymphoma, the infiltrate must be present as a lymphoepithelial lesion, which is a discrete cluster of 3 or more lymphocytes. In summary, in lymphoma, it is the discrete cluster of lymphocytes called the lymphoepithelial lesion which is present, while in the lymphocytic gastritis, there is not the cluster of the lymphocyte, but individual single cells within the epithelium are present. This is the differentiating feature between the malt lymphoma and the lymphocytic gastritis. Next is the diffuse large cell B cell lymphoma. These are most high-grade gastric lymphomas. Major diagnostic challenge is to separate the diffuse large cell B cell lymphomas from the poorly differentiated carcinoma. Lymphoma cells tends to infiltrate widely in the lamina propria in a sheet-like fashion, but they often spare the existing gastric pits and gland. In contrast to marked lymphomas, lymphoepithelial lesion is not a common finding in diffuse large B-cell lymphomas. Now the mesenchymal tumor. Most gastrointestinal mesenchymal neoplasms are the gastrointestinal stromal tumors of smooth muscle types. Previously, the term GIST was applied to mesenchymal tumors of all types, but at present, the diagnosis of the GIST should be restricted to neoplasm arising from the interstitial cells of Cajal, which are the GI pacemaker cells. Tumors arising from the smooth muscles should be called leiomyoma or leiomyosarcoma if malignant, and those arising from the nerves should be called schwannoma or neurosarcoma. This table is summarizing the gastric mesenchymal neoplasm, benign and malignant, benign on the left side and malignant on the right side. Benign include the spindle cell gist, epithelioid gist. These are the two types of the gist, and there are malignant spindle cell gist and malignant epithelioid gist. Then the leiomyoma, benign tumor of the smooth muscle, leiomyosarcoma, malignant tumor of the smooth muscle, schwannoma and pleomorphic sarcoma, glomus tumor, rhabdomyosarcoma, and lipoma and mesenchyma as benign tumors, and malignant fibrous histiocytoma and liposarcoma are the malignant tumors. GIST accounts for 2% of all the malignant gastric tumors, typically defined as tumors whose behavior is driven by the mutations in KIT genes or PDGFRA gene and may or may not stain positive for KIT. The age of incidence is between the 5th and 8th decade of life, and the male to female ratio is equal. Pathophysiology. GIST thought to arise from the interstitial cells of Cajal. What is interstitial cells of Cajal? These are the type of interstitial cell found in the gastrointestinal tract that serves as a pacemaker which creates the basal electrical rhythm leading to contraction of the smooth muscle, that is peristalsis. Most of the GIST arise because of the mutation of the c-KIT genes. c-KIT or CD117 is expressed in interstitial cells of Cajal. GIST are mostly sporadic, but some forms of the GIST can be hereditary. There are 8 different histologic subtypes. Spindle cell GIST has 4 subtypes and epithelioid cell GIST have 4 subtypes. Spindle cell GIST constitute 20% of all the stromal tumor. The 4 subtypes include the sclerosing, palisadin, hypercellular and sarcomatous. While the epithelioid GIST involves the corpus and the antrum of the stomach, and 4 subtypes include the sclerosing, palisadin, hypercellular and sarcomatous. Thank you very much for your patient listening. That's all about the stomach. In first lecture we discussed the anatomy, in second lecture we discussed the physiology, and lastly in this third lecture we discussed the pathological conditions of the stomach.